Ya empezó a grabar, entonces iniciamos. Good afternoon, class. The topic today is cognitive rehabilitation. I share the PowerPoint. And the first thing that when I speak about of cognitive rehabilitation, the first thing important is know about cognition. But cognition is a topic that in this team, in this class, we about cognition every class. Cognition is the mental faculty of knowing, which includes perceiving, recognizing, conceiving, judging, reasoning, and imagining. Okay? Is memory, is perception, is cognitive function. For example, executive function is all about function of cognitive function. Memory, attention, this is cognition. The cognition is very important in neuropsychology because the neuropsychology study when there are the brain there are the damage about of cognition. It's very important for the neuropsychology study or assessment about of the problem in the cognition. Neurocognitive rehabilitation. One of the main theoretical forerunners of modern cognitive rehabilitation techniques was Alexander Luria. Alexander Luria is a very important person in this topic because he, esperen un momento que se me olvidó una palabra en inglés. One second, please. I don't remember one word. He developing neurocognitive rehabilitation with people that have brain damage. Luria is very important for this topic. And Oliver Sandwell is other person very important. The British Sandwell is considered one of the pioneers of modern rehabilitation cognitive, being the author who proposed the main cognitive rehabilitation techniques: compensation, replacement, and relearning. These three verbs is very important for this topic: compensation, replacement, and relearning. The theory about of neurocognitive rehabilitation have these concepts: compensation, replacement, and relearning. It's very important, these three verbs. Cognitive impairment is an inclusive term to describe any characteristic that acts as a barrier to the cognition process. The term may describe deficits in overall intelligence, specific and restricted deficits in cognitive abilities, neuropsychological deficits. Cognitive impairment is other word very important in this topic. Maybe I think if you can to translate this word, please. For example, translate these words, please. Please translate, students, please translate these words for understand better this topic, please. No. Ay, no puede ser. Yo entré a otra clase. Ay, Dios mío, no sé qué me está... Es, this is the word, excuse me. Brain damage, brain injury. Oh my God. Cognitive impairment. Cognitive disability. This word, please. María Firavitova, brain damage, daño cerebral. Very good. Very good, María. Please search these words, students. Okay, brain injury, lesión cerebral, very good. Okay, María, disfunción cognitiva. Cognitive disabilities. Disfunción cognitiva. Disfunción cognitiva. Ok, difusión no. Difusión is the communication. Ok, disfunción cognitiva.
Lo siento, profe, me comí la S.
No problem. Pero mira que nosotros nos comemos una letra y cambia totalmente. Difusión es más de comunicación. Ok. Discapacidad cognitiva. Very good, Manuel. Disabilities, cognitive disabilities. The others, please, Janicer, Karen Ramírez, Ángela Salcedo, Manuel, Angie Tatiana, Carolina, Gaby. The others, please, answer. Marcela Bernal, Nicole Juliet Balbuena, Alexandra Hernández, Solange Prieto. Please translate these words, compensation, replacement, and relearning. Ok. Janicer, compensación, reemplazo, very good. Relearning. Relearning. Reaprendizaje. Training is other words very important is cognitive training. Reaprender. Cognitive training. Entrenamiento cognitivo. Very good. Very good, María. These words are very important in this topic. For this is important that you for understanding this. Okay. I again with my PowerPoint and cognitive impairment. You know what is cognitive impairment? It's an inclusive term to describe any characteristic that acts as a barrier to the cognition process. Deficits in overall intelligence, specific restricted deficits in cognitive abilities, neuropsychological deficits. Epidemiology of cognitive impairment. A cross-sectional study was carried out in 2010, found out prevalence of cognitive impairment as 3.5%. The prevalence of cognitive impairment in the study population among elderly adults, the concept of cognitive disability.
Creo que no estás compartiendo.
I can see the presentation.
Okay. Again. Ay, Dios mío, ¿qué será eso?
Much better, teacher.
Okay. Can you see the PowerPoint?
Of course.
Okay. Yes, I can. Bien. Epidemiology of cognitive impairment. A cross-sectional study was carried out in 2010, found out prevalence of cognitive impairment as 3.5%. Is low. Is low. This percent is low, but in the time, maybe there are more cases and the epidemiology maybe is more high. The problems with the people, for example, dementia. Dementia is a illness very difficult for treatment for all. Dementia is a cognitive impairment, and maybe in the future this this 3.5% maybe is more in the future for the dementia, because dementia is a neurodegenerative illness, very bad, and maybe these statistics hike, can to hike. Okay, again. The prevalence of cognitive impairment in the study population among elderly adults aged over 16 years of both sex was 8.8%. If one were able to successfully treat mild cognitive impairment such that the progression of individuals to
Uncalled, delayed of the years and were significant saving. Of course.
¿Quién habla? Okay. If one were able to successfully treat mild cognitive impairment such that the progression of these individuals to AD is Alzheimer's disease, could be delayed by 1 year. There would be significant savings. Yes, because the Alzheimer's disease, dementia, Levy corpse, Parkinson disease is a problem, is a neurodegenerative illness, but maybe these percents may be high in the future. This is the epidemiology. I can't see. My God. The concept of cognitive disability is extremely broad, not always well defined, have greater difficulty with one or more types of mental tasks. Yes, you translate this concept of cognitive disabilities. There are problems in the cognitive functions. Hay alguien con el micrófono abierto y hace ruido. Manuel. Manuel, ¿tú quieres hablar? Manuel, do you want to speak? No, are you sure? I think maybe yes. Okay. Classification, clinical disabilities, functional disability. Clinical diagnosis of cognitive disabilities include traumatic brain injury, TBE, and even dementia. Dementia is a neurodegenerative illness. You studied the last week this concept of dementia, Alzheimer's disease, Parkinson disease, body Levy disease, and body Levy dementia, body Levy's dementia, and vascular dementia, and Huntington dementia, and frontotemporal dementia. There are many types of dementia, more or less 100. Autism, Down syndrome. This is a diagnosis of cognitive disability, no? More or less, this is the more frequently in this disabilitation, in this cognitive disabilitation. Traumatic brain injury is a word very used for explain when the people have, for example, a traumatic shock in the head, or maybe a accident, brain vascular accident, and other types of illness. Less severe cognitive conditions include attention deficit disorders, dyslexia, difficulty reading, dyscalculia, difficulty with math, and learning disabilities in general. This classification is more big because there are all types of problems with the cognitive functions. Some of the main categories of functional cognitive disabilities include deficits or difficulties, executive functions, behavior, working memory, and planning, and memory, semantic memory, episodic memory, working memory, there are more types of memory. Information processing, yes, visual processing and attention. This is more or less the faculty cognitives about of the disabilities have problems. Attention, selective attention. For example, this is types of the dysfunction, attention, selective attention, sustained attention, alternating attention, divided attention. You study this form: memory, visual memory, auditory memory, working memory, episodic memory, semantic memory, procedural memory, executive function, initiation, processing speed, problem solving, and planning. Maybe one student, do you want to translate these words, please? Please, students. A student translates the word, please. Use the microphone. A student, please use the microphone.
Memoria de trabajo, profe.
Okay. Working memory, memoria de trabajo, very good.
Memoria episódica.
Bien, very good, good. Continuous, please.
Atención selectiva.
Atención selectiva. Okay, very good.
Atención dividida.
Sí, sí.
Procesamiento rápido, creo.
Procesamiento rápido. Velocidad del procesamiento. Pero good, ¿por qué? Porque, o sea, está muy bien que tú trates de hacer la traducción, porque de pronto si hay algo que queda mal, se puede arreglar, se puede enseñar el término. Sí, importante es que se familiaricen. Entonces, processing speed, velocidad de procesamiento. Very good. Other word? Problem solving.
Planeación.
Planning, planeación, sí. For example, auditory memory. What do you...
Resolución de problemas.
Resolución de problemas. Problem solving, yes.
Atención sostenida.
Ok, atención sostenida. Sustained attention, yes. Okay, very good, very good. For example, auditory memory, memoria auditiva. Working memory, memoria de trabajo. Episodic memory, memoria episódica. Semantic memory, memoria semántica. Procedural memory, memoria procedimental. Memoria motora, ¿sí? Digamos, esa memoria que nosotros hemos estudiado más de tipo motor. Entonces, esa sería la memoria procedimental. Very good, thank you. And continues with the PowerPoint. Cognitive rehabilitation is a complex collection of techniques designed to enhance perception, attention, comprehension, learning, remembering, problem solving, reasoning, and so forth in individuals who have impairments in these areas. Cognitive rehabilitation is a therapy for people that have problems in their cognitive functions. For example, one person has problems in memory and he needs a cognitive rehabilitation, okay? There are exercises about of memory for help to this person in memory, for example, episodic memory, recall, procedural memory. Yes, there are centers very specific in memory. There are programs programs in cognitive rehabilitation very specific in memory, because the memory is the most important cognitive function in the person, in the people, because the memory have other system of cognitive function. For example, perception. If you don't have memory, don't remember the name about of the objects. For example, motor skills. If you don't remember how do you to do the movements for reach the task, maybe you have problem for example, do the coffee in the morning. Maybe you don't remember how I can to do the coffee in the morning. There are these problems, and these problems have relation about of the memory, okay? More or less cognitive rehabilitation. After you see you watch a video for remember this topic. Neurocognitive rehabilitation, the increasing incorporation of diverse professionals facilitating the approach of the damaged brain from a multi-professional perspective. Along with neuropsychologists, in the brain damage care team includes professionals from various fields: occupational therapy, physical therapy, neurology, neurosurgery, psychiatry, clinical psychology, speech therapy, social work, nursing, or special education. Okay, this neurocognitive rehabilitation need other professional, not only neuropsychological professional. The neurocognitive rehabilitation need, for example, occupational therapy. This professional have tasks about of the occupational therapy for the patient. Physical therapy. This professional have the therapy about of the physical, the movements, the muscle, the all things about the physical therapy. Neurology describe or reset the drugs for the brain. Neurosurgery have a neurosurgery about of the brain. Maybe he put the electrodes or maybe he put the chips in the brain for help the patient. Psychiatric, when the people have a neurodegenerative illness, for example, Alzheimer's disease, the psychiatric reset the drugs for the behavior of the patient, for enhance the behavior, for example. And clinical psychology, this professional work with the family, for example, when the family have one person with Alzheimer's disease, this is very difficult for the family. For this reason, clinical neuropsychology help to the family, help to the people very near of the patient. Speech therapy is about of the phonoaudiology. For example, in our country is the phonoaudiology. Is the person that have exercise about of vocalization, about of songs, about of speech for the patient. And social work works with the family. They works with the family and the patient. Nursing, yes, nursing is very important, or special education, and neuropsychology. Neuropsychology assessment, the problems with the cognitive function, in the cognitive function. Okay, there are questions in this topic. Are there questions? Okay. Okay, well, see this, please, see, watch this. Yes. See, watch this video. You watch this video, please, and you watch this video. And you write 3 main ideas about this. Okay. You have 5 minutes for this work. Please see this link and put the words in English for reinforce English. Subtitles, please, for understand. And you have 5 minutes for write 3 main ideas about of this link, okay? Ok, boys. Manuel Arévalo, ¿en qué consiste la rehabilitación neuropsicológica y según la doctora, cuáles son los focos? La familia, la independencia del consultante, etc. Ok, rehabilitation, neuropsychological rehabilitation is very important when the patient have brain injury. The family is very important for the rehabilitation neuropsychology. And the problems, the problems more important in the neuropsychological rehabilitation is problems in memory, in perception, in aphasia, for example, dyscalculia, all disabilities cognitive. Cognitive rehabilitation is positive as long as there is commitment and participation of the family and the patient. Yes. The rehabilitation will generate independency again. Yes. It is a multidisciplinary work. Yes. Very good, Carolina Figueroa. Good ideas. For example, the neurologists with the neuropsychologists, yes, and speech therapy and physical therapy and occupational therapy, other professionals. Rehabilitation has short-term and long-term, yes, goals to make it more effective, yes. There are short-term and long-term goals because the problems in the brain is not easy for intervention. For example, problems in memory need time, need 1 or 2 times in the week for stimulation, for training, for cognitive training. And in this idea, the rehabilitation has short-term and long-term goals. It's very important for the patient. Okay, Maria Firavitova is right, other idea. And for example, Angie Tatiana Uribe, what is your main idea? Gaby. Okay, Ángela Salcedo Perilla, give family tools to help with the cognitive rehabilitation, yes. María Firavitova, put the puzzle piece back together, yes. For example, the brain damage, the woman, the neuropsychological woman, she said, it's a puzzle. The brain is a puzzle when they have injury. When the brain have an injury, maybe the brain is a puzzle that these puzzle are broken, and you need put the piece exactly in the brain. For this, she compared the brain with a puzzle. Help rehabilitation impairments such as attention, memory, perception. Yes, very good. Very good ideas. Okay. Okay, Carolina. Gaby, accompany family members and give them to help patient. Yes, it's very important, Gaby. In our culture, the medics and nurses don't work with the families, but the work with the families is very, very important. I work with the families that have one member with brain injury, and it's very difficult. This member that care the patient is caregiver, the caregiver. And there are moments when the caregiver have many stress, many depression. For this is very important the intervention of caregiver. And Solange Prieto, your idea. Alexandra Hernandez. Alexandra Hernandez, don't write. Nicole Juliet Balbuena, please, your idea. And Janicer, please. Janicer, you speak very well English. Please write me one idea about the video. Okay, I come back to the PowerPoint. Form of establishment brain damage. In general, sudden onset brain damage produce a more striking symptomatology than that of progressive onset. Certain processes such as strokes or traumatic brain injury create a more intense neurological and neuropsychological symptoms than tumors brain or ischemic brain process. Consequently, the possibilities of rehabilitation in the sudden onset brain injury are usually greater than in the progressive establishment. Injury severity, brain damage. Generally speaking, the greater the extent of brain damage, the greater the alteration of cognitive process, are to those of greater complexity tend to have better recovery, since more functional areas are involved. Okay, in this PowerPoint, you see Broca areas, auditive cortex, visual cortex, angular gyro, Wernicke's areas, motor cortex, okay? If you have a injury in Broca's areas, maybe you can speak because it's an area very especially in the speech, and for this you need the neurocognitive rehabilitation. But what happened? This area is very important. Maybe if you have problem in this area, you need more rehabilitation, or your rehabilitation is very different, that you have problems in other area, no more specific, no more especially. For example, one area without especially function. Your rehabilitation when you have injury in Broca areas is more complex if you have other injury in other part of the brain that not a specialty area. Okay, I don't know if you understand. Incomplete injuries of a brain area recover more easily than complete injuries, since the brain neuroplasticity can facilitate functional improvement for preserve the areas. Other things about this, about neurocognitive rehabilitation, is the neuroplasticity. Neuroplasticity is very important for the brain because neuroplasticity neuroplasticity do the born about new cellular neurons, born new cellular neurons in the brain. For this is very important the neuroplasticity process in the neurocognitive rehabilitation. What is cognitive rehabilitation? Treatment designed to help people recover from mental function that are lost or impairment following a brain injury. Different rehabilitation approach is 3. Restoring, substitution, restructuring. Restoring, cognitive training and retraining strategies meant to strengthen and restore one function. For this is very important, for example, in memory, maybe you training your brain in memory. Your cognitive training is about of the memory. All the day you have exercise for training your memory. This is restoration. Substitution, compensatory device that help to replace a lost function. Maybe there are problems with memory and you need replace a lost function. Maybe if you don't remember the activities in your work, you need an electronic agent. This agent help you for remember your activities daily, okay? For example, I don't remember that I need to call our 3 p.m. or 4 p.m., but this electronic agent remember you that you need this call. For this, there are people that have objects in their life. For example, electronic agent is very well for memory. When the people lose the memory and it's very difficult again a treatment for repair this brain, this damage. Restructuring, environmental restructuring, changing family demands places on the individual using educational and vocational facilities following the patient in their environments. Okay, in this restructuring, there are, no, in Colombia maybe it's not very, it's not very, not very developed. It's not very developed, and there are other countries that have a machinery or machine very sophisticated for the patient. For example, wait me one moment, wait me a second. Wait me a second for search the imagining, please. Okay, students, this is, for example, a restructuring environmental. This, for example, this machine is for the patient because there are people that have problems for mobilize. And when the patient have problems with their mobilize, need a machine for help this patient. This machine is not very common in Colombia, but in other countries maybe yes. But this is very people have a problem for mobilize. Restoring and recovery. They are inspired by the basic principles that the successive repetition of an activity that has been abolished by brain damage can produce a progressive impairment in it. We can differ in two modalities of restoration and recovery from brain damage. So restoration is when the brain may be spontaneous or maybe with cognitive training, the brain recovery, the cognitive fusion loss. For example, spontaneous recovery. The brain itself during the weeks after the injury tends to promote a total or partial recovery of the affect functions. It's a functions of the brain because the brain have neuroplasticity and maybe the patient recovery, the spontaneous for their function, their cognitive function loss. This process of partial or total restoring is done spontaneously, even in case where recovery is slower over several years. Restoring induced. Restoration induced restoring stimulation and training of residual capacities that have been affected by subsequent brain damage produce functional improvement. It's now demonstrated that stimulation produces increased metabolism in affect cortical areas. But this is very important. When you have cognitive rehabilitation, the brain increases the metabolism. The metabolism is when the brain needs more sugar, need more oxygen for have attacks, cognitive tasks. And for this, the neurocognitive rehabilitation is done good that than the drugs, the neurology drugs. The neurological rehabilitation, and there are articles, scientific articles and papers that explain the neuropsychological rehabilitation increase the metabolism, the brain metabolism, and help the brain for recovery, the lost function cognitive. People who have suffered a cerebral stroke with immobilization of a limb by paralysis improve cerebral reperfusion of motor areas when they are forced to use said member in an activity way. Compensation and substitution. By substitution is understood the construction of a new method of response that replaces the damage produced after brain injury. It is based on the principle that brain mechanisms and cognitive process affect in several cases have a low capacity for recovery. Maybe compensation as substitution is when the people, it's very difficult that the people recover the lost cognitive function. For this, maybe the compensation is, for example, electronic agent. When the people have or remember the daily activities with an electronic agent, this electronic agent remember the activities in the day. For this, maybe the patient need compensation or substitution, the lost cognitive function. Compensation and substitution. When complete loss of a certain functional system occurs as a consequence of brain damage. Compensation is used from another preserved brain system using substitution techniques, which consists of providence behavioral alternatives to compensate for the deficit. This type of intersystematic cognitive rehabilitation consists of training the patient to activate other functional systems when brain damage was occurred. Compensation and substitution, the use of prostheses in people with paralysis or the possibility of using the mouth or neck as a resource to control the environment in smart homes. For example, this in smart homes, this machine, for example, smart homes are some examples of compensation mechanisms that aim to adapt the subject's environment to their new needs after the injury. Other examples of intersystematic substitution techniques are use some books with the blind. Teach the patient to use the left hand in case of right hemiplegia. Adapt the subject's environment to his new situation using adapters to eat, cook, or get dressed. Mixed strategies. Mixed strategies is substitution, compensation, and restoration. Mixed strategies, the different restoration and replacement rehabilitation strategies can be used in combination in the context of cognitive rehabilitation. What should be the technique to be used in each case? Intrasystemic or intersystemic? It's a decision that will vary depend on the needs of each case. Mixed strategies. Both approaches are not mutually exclusive and are typically used in combination to retrieve brain damage. Even in the same process of treating brain damage, modify strategies through the rehabilitation process depending on the degree of recovery and improvement experienced by the patient at all times. Use. Neglect and apraxia, rehabilitation after stroke, attention training after TBE, a traumatic brain injury, memory rehabilitation with compensatory training in patients with mild dementia. Okay, in this case, are there questions? Please, you write one idea about of neurocognitive rehabilitation. Okay, thank you, Angela. Please, you write one idea about of neurocognitive rehabilitation, please. For this, you have 3 minutes. Okay, students, the ideas, please. What is the ideas about of neurocognitive rehabilitation, please? Student, one idea. Write one idea. Angie Tatiana Uribe, please write. Carolina Figueroa, the importance of neurocognitive rehabilitation in relation to neuropsychology is to put aside the pharmacological aspect a bit and improve the cognitive deficit degenerate by any situation. Okay, yes, is important in relation to neuropsychology. Okay, good, Carolina. Angie, please. One idea, right? Angie, are you in class? Angie, are you in class? Janice, Jessica, Marcela. Karen Ramírez, please. Alexandra. Nicole Balbuena. Janice, this is a work 5 minutes ago. Okay, write one idea about of you understand about the neurocognitive rehabilitation. Okay, Carolina, we can generate cognitive skills that help reinforce those that have been totally damaged. Okay, very good, Carolina, good idea. Angie Tatiana Uribe, cognitive rehabilitation refers to a wide range of evidence-based intervention designed to improve cognitive function, yes, in people with brain damage or cognitive impairment, to restore normal function or to compensate for cognitive deficit. Very good, Angie, very good. Okay, return to PowerPoint. Goal identification. Use the neurological rehabilitation, neglect and apraxia rehabilitation after a stroke. Okay, this diapositive I read before. Attention training after TBE, memory rehabilitation with compensatory training in patients with mild amnesia. Goal identification. A person may wish to address more general memory problems, or person may a specific area of concern she or he would like to work on. And the rehabilitation should depend on the focus of the individual. Yes, this is very important. There are people that have brain damage, but the needs about of cognitive function is very individual. It's very individual needs because not all the people need the same therapy, the same intensity, the same damage in the cognitive function. Only people have different needs in neurological rehabilitation, in neuropsychological rehabilitation. For this, the therapy is very individually. It's very individual. The person can be assisted in eliciting goals either informally through the discussion or by using a structured goal setting approach like Vanguard goal setting interview or Canadian occupational performance measure. It's very important to remember that the people that have brain damage need an individual therapy, not the same therapy. Maybe in the practice you see a group of the people that they receive a memory therapy, but this is a stimulation, but not rehabilitation. When you have a rehabilitation process, you need in the first thing is assessment about of your cognitive function. After of this assessment with 1, 2, or 3 tests, you receive what is the problem in your brain and you need take a therapy, a rehabilitation therapy. And this rehabilitation therapy help you in your needs, For this process is very individual, process for the needs of each patient. No is the same for all patients. No is the same for a group patient. No, it's very individual. Okay, well, I think maybe you understand. Principle: cognitive rehabilitation operates on the principle that enriches and enhances learning environments can promote gains via neuronal plasticity. This is Carolina Center for Cognitive Rehabilitation. In this topic is very important in the United States. The family education is and support network is very important for the rehabilitation with the patient. This is a topic or theme that in Colombia is very low. The works with the family is very lower because the family, the therapists don't take the family, and the family is very, very important for the rehabilitation process. And in Colombia, we need a programs with education with the family about this topic. In Colombia, for example, I work in my research more or less 100 familiar caregivers and their patients, and there are problems in the family with the patient. It is very, very important, this help for the family, but in Colombia it's very low. It's very low, this help. Maybe we need to promote this program for the family, because this is very important for the enhance the scores in the patient. What is cognitive rehabilitation and what is not cognitive rehabilitation? Cognitive rehabilitation concerns information processing. Cognitive rehabilitation is equal a cognitive retraining, cognitive remediation. But is different. Psychotherapy influence patient image on self and surroundings. Psychoactive drugs target brain receptors. Cognitive rehabilitation is a rehabilitation of cognitive function, that memory, perception, speech, and all judgment, analysis, processing speed, executive functions, working memory, all cognitive function. But there are no rehabilitation cognitive. What? How what? Psychoactive drugs. Psychoactive drugs is very different than rehabilitation cognitive. Psychoactive drugs is a drugs of the neurology reset to the patient, but is not rehabilitation cognitive. Clinical therapy, for example, clinical therapy is different that rehabilitation cognitive. Is very different because the clinical psychotherapy help the family for expression, the emotion, the feels, the frustration, but it's not rehabilitation cognitive. It's very different. And cognitive rehabilitation concerns information processing. Maybe when you go to the meet for rehabilitation cognitive, the neuropsychology explain about of the rehabilitation cognitive, but this is information, but not is the rehabilitation cognitive. The rehabilitation cognitive is an exercise for enhance the cognitive process. For example, memory. You training your memory with exercise, maybe in software, maybe in your paper. You read, you remember the words, you remember the figures, depend of the exercise, okay? but there are things that is not cognitive rehabilitation. For example, psychoactive drugs, clinical psychotherapy, and information, only information about neurocognitive rehabilitation is not a rehabilitation cognitive. Okay? Okay, this is a video about this, but maybe I speak more about what is computer-set cognitive rehabilitation. Okay, the neurocognitive rehabilitation use the computer, use the software. There are programs very interesting about of training the cognitive function, memory, perception, all cognitive function. And there are programs in the computer very good for our families, for our patient, elderly, for enhance the memory, for enhance the speech, for enhance the perception. There are programs in the software very good. The next class I speak about this. Okay. In this topic, are there questions? Okay, Janicer, neurocognitive rehabilitation utilities like mixture of treatment and strategies that helps to improve a patient quality of life. Yes. The therapies used can address the various functions like language, motor, cognitive, and neuro and psychological impairments that can be caused by brain tumors. Okay, very good. Okay. The last question. The last question. What is not rehabilitation? What is not neuropsychological rehabilitation? What is not neuropsychological rehabilitation, please? Maria Firavitova, psychotherapy, yes. Clinical psychotherapy. Okay. The next class, I explain this topic again, very short, no? In this moment, I take the list. Arevalo dice clinical Clinical therapy. Ok, y drugs, ¿no? Neurological drugs. Is very different than neuropsychological rehabilitation. Ok. La lista de asistencia. Por favor, Manuel Esteban está. María Fernanda Vaquero también está. María Fernanda Vaquero, si ella participó. María Fernanda. Ok. María Fernanda. Manuel Arévalo. María Fernanda Vaquero. Me parece que ella participó. Pero no. María Fernanda Vaquero, por favor. No contesta. Adriana Marcela Bernal Saldarriaga. Ok. Astrid Carolina Figueroa. Astrid Carolina Figueroa. María Fernanda Firavitova, si está. Jennifer Alexandra Hernández. Jennifer Alexandra Hernández. Ok. Gaby Alexandra Ortigosa. Gaby Alexandra Ortigosa. Sí, ella está. Solange Prieto. Sí, por ahí como que la vi, pero no participó. Solange Prieto. Karen Juliana Ramírez. Karen Juliana Ramírez. Ok. Karen Juliana Ramírez. Ángela Liliana Salcedo Perilla. Ángela, por ahí la vi. Ángela Salcedo, si ella participó, bien. Nicole Juliet Balbuena Coca. Nicole, debes participar más porque tú casi no me participas. Y están las niñas de Bucaramanga, Angie Tatiana Uribe, Jessica y Janicer. Yo no sé si Jessica está con Janicer o qué pasó. Janicer, ¿tú estás con Jessica? Angie Tatiana Uribe. Ok. Bueno, listo. Entonces hoy no faltó nadie. Chicos, por favor, mañana terminamos de ver este tema. Si hay preguntas, pues me dicen. Yo sé que esto no es muy fácil ni para mí ni para ustedes, pero la idea es que podamos como interactuar y entender el tema, de pronto familiarizarnos un poco con las palabras en inglés es lo importante. Y recuerden que para la próxima clase, o sea, de hoy en 8, tenemos la exposición del el último trabajo que vamos a hacer en este tercer corte, ¿ok? Bueno, que tengan feliz tarde, nos veremos mañana. Un saludito para todos, hasta luego.